Our next speaker is N Bluthenthal, who is a former faculty member with Drew. We miss you. Glad to have you back, Ricky. He's talking on opioid crisis and changing dynamics and routes of drug administration.
Good morning, everybody. Happy to be here again. It's been 12 years since I left. So it's been a while. But I'm still here through 9, so I'll never really go as long as I did. And then Paul Robinson. I had to go. Okay. So today I'm going to basically take some global studies that I've done with my colleague Alex Kroll in Los Angeles and San Francisco, where we've looked at the life course trajectories of drug users and put them within the context of the opiate epidemic that we're all sort of looking through. And I think it speaks to, just to cut to the chase, the fact that the opiate crisis isn't really going to go away, that it's going to be the harbinger of a whole set of health consequences that are going to be with us for 50, 60 years. And it's also when that's the case. Let's see. Okay, all right. So as I said, I'll do that. I'll highlight that and then look at our local data. One of the things that is true about drug use epidemiology is a little bit like I think in some of the discussions, the presentation we've had today, is that folks don't think about drugs as pleasurable, right? And of course, that's how most people get started. And so based on sort of that pleasure and that experience, some drugs are going to be more attractive. And some of that also has to do with the delivery system, right? And one of the things that's the real problem with the opiate situation is that we have a really sophisticated 21st century delivery system, right? Which is medical care, pain, which is prevalent, and pharmaceutical companies, which are allowed to directly advertise to patients. So you sort of have a perfect storm of drug delivery. And it's important to keep in mind this happened to us before. I mean, basically, there was no lung cancer in the United States in the 1900s because the smokable cigarette was only just first being introduced, right? And then after a series of wars and marketing and giving cigarettes out to GIs, right, then everyone was smoking, right? And lung cancer rates went up alongside that, right? The same thing happened with alcohol, right? It's not on the same, not in the same dramatic change. Alcohol has been with us for a long time, whereas the combustible cigarette really has only been around 150 years, something like that. So it's a newer technology. So these new technologies have consequences, right? So there's lots of prescriptions that are given out every year. I can't even read it, sorry. Right, so you can see this just sort of speaks to the numbers. So the pain relievers, about 100 million prescriptions, 40 million for tranquilizers. And so it sort of creates a denominator problem in my view. So if we were worried, well, it's not personal story. So when I began doing this work in 1991, and I started because of serendipity in the HIV epidemic. So that happened. We discovered that HIV was transmitted through infectious drug use, syringes, and so that's how I got started. We kind of dealt with that problem, right? So in California, we got pharmacy access. There's not enough people with programs, but there's plenty of them, certainly in the urban areas. Now we have treatment prevention. That problem was kind of going away. Around 07, 08, I was thinking, okay, well, I don't really need to do this work anymore because the people who are at risk for it are sort of going away. So they cut aging with AIDS. And then this opiate epidemic came out, and so you expose millions, hundreds of people in the United States to opiates. Now the truth is, 95, 96% of us are going to have a problem, right? Many of us in this room are probably going to prescribe opiates, wisdom teeth removal, vasectomies, broken limbs, with no problems at all, right? But when you've exposed everybody, right, then you're capturing in that net all the possible susceptibles, right? And so now your susceptible numbers are, it's fully given an opportunity, and then you have the problem, right? So you have this 100 million exposed. That leads to 13 million people abusing in one way or another the pain relief, right? And so then we end up having heroin users, right? Because the prescription drugs are expensive. We have methods in place to make them harder to get, including like the abuse of deterrent formulation, right? Which sort of end up pushing people who begun using them in a problematic way into other drugs that are cheaper and now widely available, right? So just to give you an idea, if you were to buy an opiate prescription pill on the street, it would be in LA, it could be between $30 and $90, right? You can get a dose of heroin for $10, right? So heroin is much less expensive than the prescription opiate. Right, and so then you see these changing trends. So the opiate overdose deaths have gone up dramatically. And then you can see in 2010 when they introduced the abuse deterrent formulations for the opiate medication, the heroin overdose started to go up. Right? And that sort of continues to be the case. I think they've tripled in the last 7 or 8 years. And now we have another issue, which is these synthetic opioids, which you can buy internationally. And that market is really coming into its own. There's an enormous East Coast, you don't see it as much out here yet, East Coast fentanyl-related overdose deaths. So Baltimore had 2,000 overdose deaths last year. Vancouver has a significant problem. Actually, the Baltimore case is actually much worse than Vancouver, but you would never know by the press report. But also because Vancouver's government has stepped in much more aggressive, right? So there's overdose provincial sites all over Vancouver and the surrounding communities now, whereas that's not the case in Baltimore. So Baltimore basically relying, I think, at this point on naloxone distribution. But we're going to have to consider other approaches like drug consumption rooms, where people can use safely and have their overdoses dealt with effectively. Okay, so you've got opiates, that leads to heroin. There's some data that's been developed by NIDA that shows 1 in 15 people who use pain relievers will use heroin in 10 years. We know from the National Survey on Health and Drug Use that people who use heroin are much more likely to inject drugs. So let's say, by default, 50% for people who use heroin versus 13% for people who use methamphetamine and 3% for folks who use cocaine. So it's a much higher risk for injection. All right. So the conceptual framework we've used to sort of think about these issues is the idea of drug use generation. And what basically that speaks to is, drugs come and go, right? They wax and they wane. So in the late 60s and early 70s, heroin was the sort of most popular drug out there, the new one that was out there. That was replaced by cocaine, which was then followed by crack cocaine. And then in the 90s, we begin to get methamphetamines and prescription benzos, and then you end up now with the opiate crisis. So we can sort of begin to understand how these trends affect injection drug users by looking at this. So I've been doing work with injection drug users since 1991. So we've got a long, I had an opportunity to see the population change over time. So this is data from a study we finished in 2013. This is data from 2011 and 2013. And it was a mixed method study. We did quantitative interviews with folks, and we asked about when they started, right? So how old were you when you used stimulants for the first time? How old were you? Okay. So it allows us to sort of construct these life histories of drug use patterns, and that's the data that I'm going to present today. All right. So the first thing we noted, and this has been a couple of other people have noted this change. There's a real change in how people find their way to opiates, right? So for folks born in the 60s, prior to the 60s and the 60s, they were using opiates. They were going to start with heroin first, so that middle one there. So for the pre-60 birth cohort, 74%. For people born in the decade when I was born, it was 60%. And you can see the impact of the opiate prescription epidemic. So now, for folks born in the 80s, they're starting their opiate use with prescription medication. Right? And as I told you, so there's a whole generation of people, like when I was a kid, I grew up in LA, you know, heroin wasn't everywhere, but prescription opiates are now, right? And so that's a profound danger for people becoming heroin users, right? So, and this has been replicated in like 3 or 4 other studies. So this is a very common phenomenon. In fact, it's so much a common phenomenon that now the people are writing papers on the reverse. So there's some data now to indicate that you sort of have the opiate epidemic, which is ongoing. That led to a heroin epidemic, right? And now you have a new cohort of people, right, beginning opiates with heroin, because now heroin has become not as available, but more available than it used to be because there's a strong demand in the marketplace for it. Yeah. Oh, so this is just the age of what, whether you used it first or second, right? So the people, so the folks in the top, the first one, prescription opiates first, that means that they were younger when they used prescription opiates than when they used heroin. And so another one, heroin first, right? And then some people use the same age, right? And we didn't, you know, it was a quantitative survey, so we didn't get into the detail of if it happened at the same age, you know, which one did you do first? Right? So there's a little bit of noise there. So about 20%, 15-20% of people with the same age. Right? So, and in fact, probably we, you know, if we were to dissect these data, you know, the truth is, for that group in the pre-60s era, if they started when they were younger, you know, there weren't as many prescription opiates available for that cohort. All right. So then the next step we did was, so we looked at this measure we sort of developed called time to injection. So we used it 2 ways to sort of highlight the special risk of let me just skip this. Just to highlight the special risk of heroin in the context of drug use. So basically, there's sort of 2 measures we use. So one is your first illicit drug use, which is usually marijuana. Right? And so there's weakness with this. We didn't include like pain, you know, sniffing glue. It's usually marijuana. And then their first injection of drug, right? Now, the slide I sort of blew by. Oh, let's just go back. Oops, wrong one. Shows the general trend, and this would be true, I think, in most places in the United States. You know, that pre-60s group mostly started with heroin, and then stimulants became more popular, right? And now opiates and heroin are coming back. And then my study, I should just say that this is a question they respond to, the first drug you injected. And almost for everyone, it's heroin, not prescription opiates. Right? So, and so in fact, if people who have been following the opiate crisis for a while, there's a big focus on whether people were injecting the prescription opiates, and that certainly happened. But it's usually not at least in California, it's not as big an issue. All right, so you have this time, and then what you can see is that as the popularity of drugs changes, the time goes up, right? So the time for that earlier pre-60s group, the Vietnam era folks, they were getting to injection drug use. The average was like 7.5 years. To the 60s, right? So that's the cocaine era. It took longer, closer to 10 years. The crack cocaine era for the 70s, still in that 9 to 10 years, and now it's coming down to 6. Right? And again, that's an indication of the influence of the opiates leading to heroin, right? And this is just another indication. And this is published. This paper came out a couple of months ago. And then just to sort of, this multivariate model, looking at factors associated with injection, and there's some things you would expect. So if someone had been exposed to drug treatment, that meant they took longer. So the way you deconstruct this, that 4.22 means that they were, 4 years. That the time between the first use and their injection use was 4 years. I mean, that's not precisely the one. And then you see here, the people born in the 80s, they have sort of statistically significant sort of time to injection. And so then the next step, and this paper isn't up yet, but I'm going to submit it like Monday, later on today. So this is looking at it by drug, okay? this is the data survival table. And the key points here are that from the first time you use the drug to the first time you inject it. Is that clear? Right. So in our group, in our sample, if you the first time your time to injection from using heroin to injecting heroin is less than a year. Right? And so you see they're pretty much the same, but you can see that big difference. So heroin, when people start using heroin, they're at particular risk for injection drug use. So let me get to the implications of this, which are pretty profound. We have a bunch of health indicators in now that's really bringing to light the consequences of this phenomenon. So this is data from the National Surveillance System looking at hepatitis C rates by age cohorts. You see this big increase in the last 3 or 4 years, people 20, 29, 30, 30. In our country, if you're getting hepatitis C, 75% of the time, it's probably more than that. But 75% of the time, it's worse than that because you're infected. Right? That's a big problem. Right? Big increase in chronic hepatitis C. This is data from California, looking at age cohorts. You can see again the model in 2017, nice little bell shape. Now we got a camel. Right? Because these younger groups are getting chronic hepatitis C. Right? And again, that's driven by injection drug use. And there are a couple of other things. Infected hepatitis rates are going through the roof according to the patient sample. So we're going to have a big problem. We're going to get more outbreaks like the HIV hepatitis C outbreak in Scott County, Indiana. We're going to have more acute hepatitis C. We're going to get more abscesses, sepsis. So there are a whole set of health consequences that are going to be driven by this opiate epidemic, to heroin, to injection. So thank you. Now it's my co-authors, funding from data and references.
Thank you. Time for questions? Shotzi? If you want to go to the microphone.
Thank you. So when you look at the globally, that one country Russia, United States, and also South Africa, they are, they stand out in terms of their substance. And the question for me is that 3 countries focus on differences in demographic indexes. Have you had a chance to look at the test your hypothesis or apply different compare what you've done here with other countries? What's the reason that these countries different such a demographic index stand out?
Yeah, I mean, I think we make our understanding of substance use needlessly complicated. I mean, my view is, and I haven't done studies in South Africa and the other place you mentioned, but if the drug is available, some portion of a population will use it, period. It doesn't really matter what it is. And so, whether it spreads has a lot to do with the pharmacokinetic qualities of the drug, how people use it in the community, right? What else is going on in the community? One of the reasons why most of us can be exposed to opiate prescription medication not a problem, at least in this room, is, look, we have rich, full lives, right? And the penalties associated with drug use are certainly sufficient to keep us from getting into trouble. But when you expose everyone, then your group of susceptibles gets really big. So I don't know. I'm sure there are national cultural differences in drug use patterns. But I also think, like Iran has a huge drug use problem. And that's because they're next to Afghanistan, which has a dozen drugs, right? So they have a lot of drugs, so they have a lot of heroin. So mostly it's driven by, if it's there, people will use it.
Last question. For break.
A couple of short questions.
One question. One question. If you want to go for break.
Well, I asked 3 questions, 1 sentence. What is the concurrent use of both heroin and opiate drugs? And also, when it comes to management of pain, there is a new health disparity among minority individuals. They are under than something, especially people 55 years and older, pain, etc. So that leads to some other issues. So any comment on that one? How do you control for pain in your study?
Well, we have a proposal that's getting reviewed October 23rd and 24th, hopefully October 23rd. That's looking at opiate use and pain in the context of medical cannabis. So I have a better answer for you. In this study, we did not ask about pain, but it's important to realize that in my study, these folks have been using drugs for many, many years. So the average, it's like 27 years. So they're not a good sample for answering that question. And then in terms of co-use of prescription opiates and heroin, again, heroin is much cheaper. 60, 70% of the folks in my sample are homeless, right? So they would prefer to use prescription opiates, but they don't have money for that. So they're mostly just using heroin. So you have to go into sort of different populations, I think, to get an adequate answer to that question. But from doing the life course history interviews, basically what happens is once people's supply of prescription opiates either become more expensive or otherwise unavailable to them, people do transition to heroin pretty quickly if it's available in the market, right? So if it's where they live and it's a viable option, then they will move to that quicker because it's 10 to 30 times less expensive, substantially less expensive than prescription medication.
So we have to raise the price of heroin.
Or, so here's my crazy thought,
Yeah.
and this gets about a little bit what Dr. Grant said. So,
Okay.
no. We make treatment hard to get to. We make it hard to stay in. And the fact of the matter is, the wise thing would be to make treatment easier and less expensive than illicit drugs, right? Then you would give people a reasonable alternative.
Great talk, Ricky. Good to see you. Okay, please come back at 11:05. Okay, 7-minute break. Sorry. Good to see you. Thanks. Beautiful.